A mechanical pump, known as a left ventricular assist device, or LVAD, takes over the function of a failing heart ventricle. Here I am going to talk about the basic function of an LVAD as well as a brief history, indication, and patients eligible to receive LVAD implants. Just to give you an overview, an LVAD is a mechanical pump attached to the heart that is surgically installed. An LVAD is not the same as an artificial heart. An artificial heart totally replaces the failing heart, whereas an LVAD assists the heart in pumping more blood with less effort. This is accomplished by continuously transferring blood from the left ventricle to the aorta, which then transports oxygen-rich blood throughout the body. Both internal and external components make up the LVAD. The actual pump rests on or near the left ventricle of your heart, with a tube connecting it to your aorta. A driveline is a cable that runs from the pump out through the skin and links it to a controller and power sources that are worn outside the body. To keep the pump running properly, the driveline must be linked to the controller, and the controller must be connected to electricity at all times. Batteries or electricity are used to operate the pump. Some LVADs come with an adapter that allows them to be powered by the car's battery. Each gadget comes with its own carrying case, allowing you to move around freely with your gear. LVADs were intended to serve as a bridge for patients in cardiogenic shock until a donor's heart became available when cardiac transplantation was first performed in Cape Town, South Africa, and elsewhere around the world. The first ventricular assist devices were paracorporeal, with external VADs supplying blood. The first of these were implanted in the late 1960s. The photo on the left side is the prototype of the first left ventricular assist device, which became the Thoratec XVE and the HeartMate. Dr. William Pierce invented a pneumatic heart support device at Penn State University 50 years ago. This device evolved into the Thoratec pneumatic VAD, which was one of the first VADs to be approved as a bridge to transplant by the Food and Drug Administration. It has since been then utilized as a bridge to transplant for ventricular assistance in over 4,000 patients. The HeartMate 1, a pulsatile device that was originally utilized as a BTT or bridge to transplant over 25 years ago, derived from this technology. On the right side is the latest VAD called the HeartMate 3, produced by Abbott Pharmaceuticals. Let's see a short video on how this device is being used for patients with advanced heart failure.
Heart failure is one of the biggest problems of mankind.
The technology has progressed so far that you can basically bring someone back from the brink of death.
It's really a life-changing technology.
The potential for how many people with heart failure could be impacted and helped is massive. It is one of the most common diseases that we face, arguably one of the #1 causes of death. Heart failure just basically means that you're not getting enough blood flow to your body. It gets to the point where you can have sudden death.
My journey with heart failure started with our third pregnancy.
She couldn't eat, she couldn't walk, she could not function at all.
There's really only about 3,000 hearts every year for transplant. This shortage of hearts for people with advanced heart failure is only going to get worse. Some form of a mechanical substitute for a heart, a left ventricular assist device. They make up for that deficit. It's a mechanical heart pump that's attached to the heart to help overcome its inability to pump blood to the rest of the body.
Here at this Zurich site, we do R&D and manufacturing for HeartMate 3.
Yeah, it's great working with Andy. He's been here for 20 years.
We have several interests which are very similar.
Nature is really close. Every now and then we'll go mountain biking over lunchtime.
So in the very early days, These devices look like this one. It's a pump that has a membrane in it. In other devices, you would generate some friction.
Human blood is very delicate. The cells might get damaged.
And when that happens, you basically have a pump that has a risk of an adverse event, like a stroke.
There were challenges to shrink it down to the size and getting the rotor stabilized. Parts became smaller, much more powerful. In 2000 or so, we brought this electronic from that size into an implantable. In the HeartMate 3, we applied the right amount of magnetic forces. The gap between the rotor part, so the thing that turns, and the thing that stays in place, is all around the rotors. They do not contact each other. This is the perfect scenario for blood cells. And this can only be achieved if you use the full maglev technology.
In these pumps, you don't see the clot formation that you did with older generation pumps. It is now comparable to a heart transplant.
As I sit here with you today, I am 3.5 months post-LVAD HeartMate 3 surgery. The kids, they're noticing as mommy gets stronger, and they'll say things about, mommy's able to do more, and they see it. They're just watching pretty much a miracle play out.
It was amazing to see the device that you've worked on for so long actually being used, and now it's helping thousands of people.
In a word, I would describe my life as having hope.
It's science, but it looks a little magical. I think that's the beauty of the thing.
These are just to show you different types of LVAD innovation. HeartMate 2 or second generation LVAD was developed after HeartMate 1. These are continuous flow LVADs where blood was propelled through a rotor. The blood flow was continuous and not pulsatile as in native hearts. These devices, as opposed to the earlier HeartMate 1, required systemic anticoagulation. The functional status and quality of life improved 3 months after implantation of the continuous flow LVADs. Major adverse events included right ventricular failure, post-operative bleeding, stroke, percutaneous lead infection, and pump thrombosis. HeartMate 2 recipients had a greater freedom from stroke or VAD replacement, indicating that the HeartMate 2 was a more durable VAD than HeartMate 1. Third-generation LVADs were continuous flow devices which had centrifugal flow, which meant that flow in the VAD was perpendicular to flow coming in from the left ventricle. These devices were smaller than HeartMate 2 and had a moving impeller suspended by magnetic and hydrodynamic forces to reduce shear and prolong LVAD durability. The archetype LVAD in this group is the Heartwear Ventricular Assist device, which was studied in the Heartwear Ventricular Assist System as Destination Therapy of Advanced Heart Failure Study. HVAD appeared to be more durable than the HeartMate 2, yet it was associated with a higher stroke rate. There are a variety of LVAD models on the market now. Each has its own engineering features and external equipment, yet they all fulfill the same purpose. Early LVADs were larger, noisier, and less durable with bulkier power sources. Today's LVADs are significantly different, just like the HeartMate 3. The quality and quantity of life for LVAD patients today are improving as LVAD technology improves. In today's LVAD, patients have a 1-year survival rate of at least 85%, allowing them to live fully and in many circumstances return to work. Advanced heart failure with medical therapy alone, on the other hand, has a 1-year survival rate of 25 to 50%. When is an LVAD used for congestive heart failure treatment? Your doctor may prescribe LVAD implant surgery if you have an advanced heart failure and your heart is no longer able to pump enough blood to meet your body's needs despite medications. LVADs are now used in 3 different ways. The first one is what we call bridge to transplant, or BTT. This is when an LVAD is installed in critically ill patients to keep them alive while waiting for a heart transplant. The patient's LVAD could stay in place for several years until a suitable heart donor becomes available. Next is what we call destination therapy. An LVAD can be installed as a permanent option if a patient is not eligible for a heart transplant. This is known as destination therapy, and it is becoming more prevalent as LVAD technology improves, as is the quality of life it provides. For example, the patient is too old to get a heart transplant, therefore the patient is going to have this device for the rest of his life. And lastly, we use LVAD as bridge to recovery. It is used to treat transient heart failure or acute insults such as cardiogenic shock. A heart may restore its strength in rare cases after being given time to rest with the help of an LVAD. We put it when the ventricle fails or when the heart has not enough pumping ability to let the heart recover. This is where the LVAD is implanted in patients who are severely hemodynamically compromised, but who, with medical circulatory support, may develop myocardial recovery to the point that the LVAD can be explanted. Who is a candidate for LVAD? Patients who are candidates for LVAD therapy have congestive heart failure symptoms with very little activity. Symptoms occur despite taking the maximum tolerable amount of heart failure medications they mouth. Patients with New York Heart Association Class 4 symptoms, which is dyspnea at rest, despite optimal guideline-directed medical therapies, who have a poor prognosis at 1 year as well as poor quality of life. Therefore, patients should be referred for LVADs if they have a New York Heart Association Class 4 symptoms despite optimal guideline-directed medical therapies, and CRT if they are candidates, or if they have recurrent hospitalizations for acute decompensated heart failure despite optimal medical guideline-directed medical therapies. VAD demonstrated significant improvement in both patient survival and functional status when compared to medical management for advanced heart failure. Refinements in device design and implantation technique have resulted in improved durability in these devices and improved patient outcomes compared to the earlier devices. Significant innovation and a further improvement in this technology is currently taking place, and it is expected that several new devices will enter clinical trials within the next 2 to 3 years. Future advances in technology are focusing on smaller pumps while still maintaining durability.
I will be discussing the benefits and risk of ventricular assistive devices and the preparation for insertion of LVAD. As discussed earlier, heart failure patient is the candidate for this procedure. The benefits of VAD is to first relieve heart's workload by helping to pump blood from the heart's lower chambers and to the rest of the organs. Patient may also experience lesser or fewer symptoms of heart failure. It also improves quality of life because patient has less fatigue, improved breathing and organ function, improve patient strength and ability to participate in activities such as cardiac rehab, and allow patient to be discharged from the hospital. Lastly is greater life expectancy. Patients with advanced heart failure who have an LVAD tend to live longer than those who are treated with medical therapy alone. All surgeries have risk factors, some of which are bleeding, which is the most common. Blood clots may form from VAD, which can slow or block blood flow, causing stroke, heart attack, and problems with the device. Next is infection. Increased risk of infection both at the incision site or the exit site where power source is attached. That's why health teaching is very important in taking care of the device. Next is device problem or malfunction. Power supply could fail and the VAD may stop working properly, which is an emergency case, and that patient and caregivers must be taught on how to respond in such events. For patients having LVAD, left ventricle pump more blood than it used to. Right ventricle may be too weak to handle, and right heart failure can happen. Temporary pump and medication may help right ventricle pump better in long term. Lastly, hemolysis or thrombus formation can happen because of damage to blood cells due to the pump. Patients are also encouraged to create advanced directives to let the treating team know their wishes concerning medical treatment in the event that patient become unable to communicate their wishes. Before a patient can undergo a VAD placement, series of tests and evaluation must be done. The VAD team, which includes the cardiac surgeon, cardiologist, social worker, VAD coordinator, PT, psychiatrist, social worker, will be the one to evaluate and determine if a patient can be a candidate for VAD. The following are the list of LVAD evaluation and must be done at least 48 to 72 hours before the scheduled surgery. These are echocardiogram, left and right cardiac catheterization. It measures the pressure of the heart and it also visualizes the coronary arteries. EKG, laboratory test can determine other diseases. If patient found to have kidney, lung, or liver failure or infection, they cannot be a candidate for an LVAD. Lab test also determines clotting factors and blood type in preparation for blood administration during the procedure. Chest X-ray and pulmonary function test is also part of the LVAD evaluation. Carotid and peripheral ultrasound is done to look for blockage in certain blood vessels. Allergies are also verified and very important. Psychosocial and psychiatric evaluation is as important as the other test because it determines the understanding and the ability of the patient and family members to take care of the patient before and after the surgery and in long-term basis. It also evaluates patients' compliance with medical regimen, coping and stress management, as well as the patient's mental health history. Availability of caregiver, social support, and family communication is imperative because these are the key component of the patient's fast recovery. In most countries, such as the US, insurance clearance is also being evaluated, which includes covering of cost of surgery as well as testing and medication after it. Once all the criteria are met, a VAD-specific consent is signed by patient and the surgeon, along with patient confirmation of receiving education about VAD. Intraoperative VAD-RN applies multi-layer soft silicone foam pressure dressing in patient sacrum to prevent skin breakdown in the perioperative and immediate postoperative periods. Recent study has shown that using this prophylactically reduces the occurrence of pressure ulcers in critically ill patients by as much as 10%. How do LVADs implanted? It is performed through open heart surgery under general anesthesia. To better understand the surgical procedure, below is a short video clip of the surgery.
What will happen after my LVAD operation?
Your LVAD operation will take 4 to 6 hours. The first incision will be made at the top center of your chest or breastbone down to your stomach area. A second small incision will be made in your abdomen near your stomach. This is where your LVAD driveline cable will exit your body. Your LVAD will be placed inside your chest near your stomach. During your operation, a heart-lung bypass machine may be needed to take over the function of your heart and lung while your surgeon is placing your LVAD. Your need for a heart-lung bypass machine will depend on your condition, the type of LVAD you're getting, and how well your heart will be able to pump during your operation. Once your heart is pumping with the help of your new LVAD, the heart-lung bypass machine will be stopped. Once your LVAD is connected to the system controller, it will take over pumping for your heart. If you needed a heart-lung bypass machine during your operation, it will be stopped and your LVAD will take over. Your surgeon will close your incision and cover it with a bandage.
When will I go home?
After your operation, you will be brought to the cardiovascular intensive care unit, also known as the CVICU. A breathing machine, or ventilator, will help you breathe until you are strong enough to breathe on your own. You will see tubes and IV lines that were put in during your operation. They will be removed when you get better. You will also see a driveline cable exit your body in your abdomen near your stomach. Everyone recovers differently after an LVAD operation. Some people may recover in as little as 3 days. Others may take longer than 7 days.
After the patient is transferred from ICU to cardiac ward, nursing management and health teaching is necessary, which will be discussed in the following slides. Nursing management for the use of ventricular assisted device. Caring for the hospitalized patient with an LVAD begins with a thorough assessment of both the patient and LVAD. Nursing management that are performed while the patients are hospitalized gives nurses the perfect opportunity to do health teachings by showing patients how to do it the right way and encouraging them to ask immediate questions during the time it is being performed. The LVAD requires regular care and system checks, including power source changes, daily self-test, and driveline dressing changes. Change between batteries and the power module as by means of switching power sources. Always change out the white power cables first and then the black cables. To change from one power source to the other, push the connectors of the white cables together and turn counterclockwise to disconnect. To reconnect, align the half moons on the connectors, push them together and turn clockwise until they're flush. Repeat the same steps with the black cables. Think power, patient power to remind yourself to disconnect and reconnect one power source at a time. Never disconnect both sets of cables at the same time. This essentially leaves the patient without a power source. When performing a daily self-test, the patient presses and holds the battery button on the system controller. The screen displays self-test. If the panel is working properly, the audio alarm will sound and control panel alarms will light up. These alarms include power and battery alarms, a red heart alarm, and a wrench alarm. Except under special circumstances, the driveline dressings must be changed daily or every other day, depending on the provider's order and how long the patient has had the LVAD. We monitor blood pressure and mean arterial pressure. The goal is 60 mmHg to 90 mmHg. If the MAP is too high, the patient may require antihypertensive drugs such as metoprolol, hydralazine, and isosorbide dinitrate. Check the LVAD each time you assess the patient's vital signs. You will hear the continuous humming of the pump when auscultating the heart. Make sure the battery changing station is plugged into the wall and at least 2 spare batteries are in the charge station. A green light indicates a full charge. The 4 P's of the LVAD consists of the pump flow, the pump speed, pulse index, and power. We monitor these key parameters on the patient's left ventricular assistive device or LVAD. Patients with LVADs are typically prescribed several medications including anticoagulants, antiplatelet agents, antihypertensives, antiarrhythmics, fluids, and electrolytes. Anticoagulants and antiplatelets help prevent pump thrombosis. However, these drugs increase hemorrhage risk. Antihypertensives, on the other hand, helps maintain sufficient pump flow. Common prescribed antihypertensive drugs include vasodilators, beta blockers, and ACE inhibitors. Fluid and electrolyte replacement. For patients with LVADs who depend on adequate volume and pressure to maintain flow, you may need to push fluids to achieve the best feeling pressures. The decision to push fluids depends on the patient's hemodynamic status. Keeping electrolytes such as potassium, magnesium, sodium, and calcium within normal ranges help prevent arrhythmias. Common LVAD complications include infection, pump thrombus, hemorrhage, arrhythmias, and suction events. Psychosocial support. Patients with LVADs experience many physical and emotional changes. Assess patients for depression on admission and throughout their hospital stay. Teach coping skills such as journaling, meditation, art therapy, prayer, and the importance of reaching out to others. Patients with LVADs can offer significant support to one another. Providing information about support groups are very helpful. Discharge teachings post-op ventricular assisted device.
At least one of the family members or caregivers need to know how to operate the LVAD device before the patient goes home. Explain to the patient that getting an LVAD is a chance for a better life, but it is a big lifestyle change, so it is normal to be concerned. Family and healthcare team, including doctors, nurses, dietitians, physiotherapists, social workers, and psychosocial support team will be there to help adjust to a patient's new life. Medication, activities, nutrition, sex, avoiding contact sports, extreme care to driveline cables, and watching out for signs of infection or any new changes are the important teachings that we need to discuss with the patient before going home after having a ventricular assisted device in place. And to end our presentation is a short video to further explain these teachings.
There are a few precautions that you will need to take with your LVAD. You will still need to take medication. In addition, you will need to take anticoagulants such as aspirin or Coumadin while you have an LVAD. After your incision for your driveline heals, a shower may be possible. Talk about this with your healthcare team. Your healthcare team will tell you when you may start showering. Do not take a bath, swim, or go underwater with your LVAD. Eat as you did before your LVAD operation as long as you do not feel any discomfort. Vitamin K affects how well blood thinner medications like Coumadin work. Try to eat about the same amount of vegetables that contain vitamin K each day to help your healthcare team adjust your Coumadin dose. Wait for your surgical wound to fully heal before having sex. Women with an LVAD will need to take precautions by using condoms and foam to avoid pregnancy. Avoid contact sports like soccer or football because you may damage your LVAD or electrical driveline. Take extreme care with your driveline cables. Your driveline sends signals and electricity to your LVAD, so any damage to your driveline could be life-threatening. Watch your system controller and listen for any alarms. Your healthcare team will tell you which serious signs and symptoms to look out for and when you will need to go to the nearest emergency room. Look for any signs of infection like redness, swelling, or pus at the spot where your LVAD driveline comes out of your skin. Talk to your healthcare team right away if you have any signs of infection or if you notice any new changes.